Once again, here's some resources that are relevant for the time of this taping. It's always possible if you're watching this in the future, there'll be new resources, better resources. And I want to thank you very much for listening to this. I hope you found this valuable, and it was a pleasure to be able to give you this seminar. Thank you so much. Goodbye.
Hello, I'm Dr. Rajesh Girdhari, and this talk is about the application of methadone guidelines to seemingly complex clinical situations, part of the Ontario Pharmacist Association online continuing education program. Rajesh Girdhari, and this talk is about the application of methadone guidelines to seemingly complex clinical situations, part of the Ontario Pharmacist Association online continuing education program. Starting with a conflict of interest, I'm a staff physician at True North Medical Center, which has several locations in Toronto and some outside of the city as well. I'm also a staff physician in the Department of Family Medicine at St. Michael's Hospital. I have no other conflicts of interest to declare. So just as an introduction, complex clinical situations arise frequently in methadone maintenance practice. Clinical situations can be called complex when they start to involve a technical medical issue related to methadone combined with an emotional, withdrawing, intoxicated, or otherwise agitated patient. In these complex clinical situations, it can be difficult to make sound decisions with the complicating circumstances. The learning objectives for this program, as set out by the Ontario Pharmacist Association, are identify current relevant standards, policies, and clinical practice guidelines available for methadone administration and dispensing, to apply standards and current clinical guidelines to seemingly complex clinical situations related to the dispensing and administration of methadone, and to discuss ways to handle or mitigate complex clinical situations, including building strong relationships with the patient as well as healthcare team involved in the care of a patient on methadone maintenance therapy, following suggested best practice for record keeping. The talk has three main parts. The first is an outline of key resource documents that you can reference in the future. The second part, and the longest part, is looking at case studies outlining the application of these guidelines to complex clinical scenarios. And the third part is a bit about interprofessional communication and the importance of record keeping. So we'll start off by reviewing key resource documents. These are the documents that sort of creates the framework for methadone maintenance therapy in Ontario. So now move on to case studies, where we'll apply guidance from these documents that we just reviewed to seemingly complex clinical scenarios. So the first case study has to do with continuation of care for a patient on MMT when the patient has a missing, unclear, or inaccurate prescription from their MMT provider. So in this case study, Mr. Jones presents to your pharmacy thinking that his methadone dose is 60 milligrams daily because that's what he just discussed with his physician earlier. However, his physician forgot to record the dose increase on the prescription, or so the patient says, and the patient's current prescription reads 45 milligrams POQD. The patient becomes very upset when he finds out that he will not be receiving a 60 milligram dose of methadone today. So what do? The Ontario College of Pharmacists MMT and dispensing policy states that a written prescription is required for the pharmacist to dispense methadone to a patient. It's important to remember in this particular case and all the case studies that will follow that a key guiding principle in MMT in Ontario is patient safety. And what that means is that methadone can be a lethal drug, particularly in overdose. And while withdrawal can be very unpleasant for patients, it is generally not considered to be lethal. Thus, in the circumstance in which you are unsure how to act in a given clinical situation, it would always err on the side of avoiding a potential overdose in a patient because that could be lethal to them. So your options in this current scenario, it's going to be very difficult for you to prescribe the patient's 60 milligrams. In fact, it's going to be impossible without getting a new prescription from the patient's MMT prescribing physician. So you have some options. Many physicians, at least in the office where I work, give their cell phones to pharmacists at pharmacies where they often send patients and with which they have a treatment relationship. So you happen to have a cell number or an office number for methadone prescriber of this particular patient. You could call them and see if you could get a new prescription written and faxed over to your pharmacy that day. If the patient's prescribing physician is not available, it's possible that a different physician in the patient's prescriber's office may be able to write that patient a prescription as well. So be sure to ask about that. It's also, as I noted already, important to have different ways to contact the physicians that regularly send patients to your pharmacy. Your other option in the circumstance would be to dispense patients the stated dose on their prescription today of 45 milligrams, and have that patient follow up with their prescribing methadone physician to get a new prescription. The next case study looks at a patient who can't provide proof of his or her last dose of methadone. So Mrs. Smith presents to your pharmacy for the first time to receive her daily MMT dose. She was previously receiving MMT from another pharmacy, but discovered that your pharmacy was closer to her home and more convenient. She presents today with a 1-week prescription written by her prescribing physician for methadone 50 milligrams POQD, witness ingestion daily. She does not have proof of last dose and becomes upset when she hears she may not receive her methadone dose immediately. So just to review that proof of the patient's last dose of methadone is required before giving that patient a methadone dose. It's important to remember that patient tolerance to methadone can decrease very rapidly in as little as only 1 or 2 days, especially early on, and as little as 2 or 3 days, particularly later on in their treatment. So again, talking about one of the key principles, which is patient safety and avoiding overdose, providing this patient with their previous dose of methadone, if they have missed only a few doses, could potentially lead to overdose and death in this patient. So a good thing to remember for MMT prescribing is that it's better to be safe than sorry. So you need to think about some options that you have in this scenario. So one would be to call the patient's previous pharmacy to get proof of their last dose. Another option is to call the patient's methadone physician if the patient's previous pharmacy is unreachable, and this physician could prescribe the patient an initiation level dose of methadone if the patient did not have any proof of their last methadone dose. And it's important to remind patients who have take-home doses of methadone, commonly called carries, that they should return these empty containers to the pharmacy as proof that they have consumed these doses. It's also important to try to remind physicians that prescribe patients methadone that you commonly see in your practice to remind patients that if they are going to get their doses filled at a new or different pharmacy, that they should bring with them proof of last dose. Moving on to the next case study. This case study looks at a patient who has missed methadone doses. So they haven't consumed them on certain days. So Mr. Johnson attends your pharmacy daily for observed MMT. He currently takes methadone 75 milligrams PO QD and has been on the same dose for several months. Today is Saturday, and his last observed dose was on Monday. So that is 4 days missed doses. He says that when you ask him why, he says that some stuff came up. He doesn't really clarify, and he wasn't able to make it to your pharmacy as usual over the past few days. But today he's asking for his usual 75 milligram dose and says that, if he gets less than that, it's going to be really hard for him. So again, in this scenario, it's important to remember that patient tolerance to methadone can decrease rapidly over only a few days, and that providing this patient with their previous dose of methadone could lead to overdose and death. It's also important to know what phase of MMT your patient is in, since the number of allowed missed doses according to the CPSO guidelines differs depending on whether or not the patient is in the early stabilization, the late stabilization, or the maintenance phase of their therapy. So the next slide shows an important table called Table 8, Management of Missed Doses. This is taken from the CPSO MMT Program Standards and Clinical Guidelines, last updated in 2011. So you can see here how the number of allowable missed doses and the action that the pharmacist and the patient's prescribing physician should take depends on the phase of treatment that the patient is in, whether it's early stabilization, usually referred to as the first 2 weeks that the patient is on methadone, or whether it's the late stabilization / maintenance phase of treatment. So this is usually after the first couple of weeks when the patient's dose has stopped increasing as much or is at a stable level. The next thing to consider is the number of doses the patient has missed, as that also affects your action. So I put this in the slides. I'm not going to review the whole table here, but I put this in the slides as a good reference for you. And we'll talk about the application of this table in a couple scenarios now. So in this particular case, remember this patient has missed 4 consecutive methadone doses, and he was in the late stabilization / maintenance phase of his treatment. So if you go back to that table 8, you can see there that this patient needs to be reassessed in person by their prescribing physician. As well, the remainder of their prescription should be canceled, and then essentially this patient should be restarted at initiation level dosing, which, assuming he did not have any high risk characteristics, would be around 30 milligrams. So you should also refuse to provide the patient with a dose of 75 milligrams, and as I said earlier, send him to be reassessed by his MMT physician. Another good option that might be worth doing in this particular circumstance is to try to explore with the patient what sort of stuff came up for him, to try and get a better understanding of why he was unable to get to the pharmacy over the past few days. If he's having trouble affording transportation, or if your hours are not convenient with his work schedule, for example, it may be possible that the patient may benefit from a different pharmacy, perhaps one closer to his home or to his work, depending on when he wants to receive his dose. You might also discover other things that it would be worth communicating to the methadone prescriber, such as legal issues or other medical or psychiatric issues that have come up for this patient. It's also important to have patients sign a contract when they begin receiving MMT at your pharmacy that clearly states that missed doses may lead to methadone dose decreases or cancellation. It's common that patients say that they're not aware that missing doses can cause their dose to decrease or be canceled altogether. Although this is one of the criteria for initiating a patient on methadone, patients are often exposed to a lot of new information when they start on methadone, and it's possible that they might not remember this. So it's good to reinforce this routinely, and also to remind the patient that the goal is to reduce their risk of overdose and death. And patients' expectations are well managed. It could help to reduce emotional outbursts, frustration on the part of patients when these situations arise. So if we look at this same case study, but we change the phase of treatment that the patient was in from the late stabilization / maintenance to the early stabilization, which is in the first couple of weeks, and we look at, so what if this patient had just missed 1 dose? So in this particular circumstance, the CPSO guidelines state that if the patient misses 1 dose during the early stabilization phase of their treatment, that patients should have no dose increases until 3 consecutive days of the same dose are consumed. So that patient could still have their dose today. However, they would need to consume 3 consecutive days of the same dose until a further increase in their dose could be considered. If that patient had, instead of missing 1 dose, had missed 2 consecutive doses, then the guidelines state that that patient needs to be reassessed by their MMT provider, that the remainder of their prescription should be canceled, and that they need to be restarted at initiation level dosing and reassessed again after 3 days if a dose increase is being considered. If the patient was in the late stabilization or maintenance phase of MMT and had missed 1 or 2 consecutive doses instead of 4 as in the initial case scenario, then in the late stabilization / maintenance phase, if the patient misses just 1 or 2 consecutive doses, the guidelines state that no change is needed in that patient's dose. However, if they miss 3 consecutive doses, in this scenario the prescription should be canceled, and the patient's methadone prescriber could consider either starting the patients on a dose that's reduced by 50% of what they were previously on, or they could just restart the patient at initiation level dosing. The guidelines also say that daily dose increases of 10 milligrams are possible for the next 3 days. So when 3 consecutive doses are missed in the late stabilization or maintenance phase of MMT, this is sort of a special circumstance where there is some more discretion for the patient's MMT prescriber to take some steps that beyond just simply canceling the patient's prescription and restarting them at initiation level doses. It is possible to restart them at a slightly higher level and to increase their dose slightly faster than would normally be expected with the usual MMT guideline for initiation. So move away from missed doses, which again I would highly encourage you to refer routinely to Table 8 from the CPSO methadone guidelines. And we'll move on now to case study 4, which looks at helping patients clarify the goals of methadone therapy. And this particular circumstance is looking at what's the difference between harm reduction therapies and abstinence-based therapies. So in this scenario, Mrs. Cole is a patient in your pharmacy just starting on MMT for opioid dependence. She is presenting to your pharmacy today for the first time. She states that, among other things, that she is only going to be on methadone for a few weeks until she can get drug-free. You might have experienced this scenario in your practice, that patients are often unaware that MMT is primarily a harm reduction therapy and is not an abstinence-based therapy. Harm reduction means that the therapy is designed to reduce the harms that patients suffer from their dependence on opioids and continued use of opioids, particularly illicit opioids, including financial harms, negative social outcomes, increased risk of infection, and so forth. And there's very good evidence that MMT is highly effective as a harm reduction therapy. On the other hand, an abstinence-based therapy is a therapy with the goal of getting the patient drug-free, usually in a short period of time. Patients should be reminded that the majority of patients who are on methadone will be on methadone for many years and possibly for the rest of their lives. Tapering off of methadone is possible, and many patients have achieved this. However, patients should be aware that it often takes years to taper completely off methadone, and even after they do, that relapse remains a possibility, and they might need to resume MMT. So patients should really discuss this with their prescribing physicians up front, and it's good for pharmacists to also help reinforce this to patients as well. And to remind patients that if they're ready, once they've achieved stability on methadone, that if they're ready to begin tapering, that this is something they should bring up with their methadone prescriber. And looking at this slide here, so if patients are unaware that their methadone is a harm reduction therapy, then patients should be encouraged to discuss this with their MMT physician, and the pharmacist should also consider calling the patient's methadone prescriber to make them aware that the patient was not aware of the treatment goals, or did not have the same treatment goals as the methadone prescriber, and the physician and the patient may decide upon further discussion to discontinue MMT or to initiate a rapid taper off of methadone once the patient's goals have either changed or been further clarified. The next scenario considers aggressive patients. Now, in any of the previous scenarios, these patients could have all become aggressive because often patients, when they present for methadone treatment, they could be in a state of relative withdrawal, particularly if they're early on in their in their treatment when their dose is not lasting yet a full 24 hours, and this is something to be considered. In addition, patients with opioid dependence could have underlying psychologic or psychiatric issues that make them less able to cope with bad news or challenging scenarios in which they're not hearing the information or getting the result that they want. In this clinical scenario, Mr. Johnson, who's the same patient, let's say from case study 3, becomes very upset in your pharmacy after being told that he can't have a 75 milligram dose of methadone because he has missed 3 consecutive doses. He aggressively says that if he doesn't get his dose now, that someone in the pharmacy will pay. He looks very menacing, and you become a little bit taken aback, and maybe even a little bit scared. However, in this circumstance, you have several options to consider, and I would say that attempting to engage the patients in an argument is not usually ever the right approach to take. So your options in this circumstance include attempting to diffuse the situation by telling the patient that you're going to call their methadone prescriber to discuss the situation with them. Could also remind the patient about the contract that they've signed, reminding them that previous encounters they've said that they understood that missing doses could lead to decreased methadone dose. And if you were proactive, you could have your patient sign a code of conduct form when initiating MMT at your pharmacy. And in this code of conduct, you may consider saying that violations of this code could result in patients being barred from receiving MMT at your pharmacy. Reminding the patients that there are many other patients both on methadone and not on methadone that come to your pharmacy, and that you need to respect their wishes and their rights to a safe space as well. I think your last option in these circumstances is to consider calling security or police. If this is what you're doing, time and again, I think you need to seriously reconsider, your approach to dealing with these aggressive patients, because calling security or police is really a last resort, and really that unfortunately you haven't been able to diffuse the situation. However, that being said, it's important to consider the safety of your staff and yourself at all times. So if you do think that calling security or police is the best route to ensuring everyone's safety, then by all means don't hesitate to do so. I would suggest that if you were going to do this, it's better to just walk out of sight of the patient and make the phone call. Just say you're going to be right back. Again, I just wanted to reinforce that attempting to engage the patient in an argument about his behavior is unlikely to help the patient, although it may make you feel somewhat better, and is not likely to improve the scenario. So the next case study considers what happens when methadone doses are lost or stolen. So in this case study, your patient, Mrs. White, who is on level 6 caries, presents to your pharmacy a couple days before her next witness dose is scheduled and states that someone stole my methadone. So in these circumstances, the CPSO MMT program standards and clinical guidelines state that, quote, lost or stolen methadone doses must be reported to the local police department. It further goes on to state that spilled, vomited, lost, or stolen doses may not necessarily be replaced for patients, and that patients who repeatedly suffer from any of the above should have their take-home dose privileges reconsidered. Again, remembering that take-home doses for patients are viewed as a privilege and not necessarily a right in MMT in Ontario. So your options in this scenario include, not replacing the stolen, lost, or spilled doses, and sending the patient to see their MMT prescriber to get a new prescription. You could also consider calling the patient's MMT prescriber, who may decide to replace the doses by writing a new prescription, in particular while the police report is being sorted out. If a new prescription is written by the patient's prescriber, you should remind that physician that considerations should be given to reducing or eliminating take-home dose privileges, especially for repeat offenders or until the patient files a police report. And I have to say, in my practice, I have seen several instances where, particularly if the patient sees multiple physicians at a particular center, that often it is the pharmacist who is flagging this for the prescriber, that the patient has needed doses replaced on several occasions. So I think this is one of the critical areas where pharmacists can play a key role in communicating with the prescribers. Next case study looks at vomited doses. Now, this is something that comes up in some circumstances, and is sort of a particular case that is outlined in the CPSO MMT guidelines. So in this case, Mrs. Green receives daily witnessed MMT in your pharmacy. 5 minutes after receiving her daily dose of methadone today, she vomits in your pharmacy. And let's say that one of your staff members witnessed Mrs. Green vomiting. So the CPSO MMT program standards and clinical guidelines in section 6.10 state that vomited methadone doses are not to be replaced unless a health professional or a staff member directly observes the patient's vomiting. If the vomiting was witnessed by the pharmacist or staff and it occurred less than 15 minutes after consumption, this dose can be replaced at no more than 50% of the regular dose. So in this case, the pharmacist should inform the prescriber and obtain a new prescription for a replacement dose. According to the Methadone Maintenance of Pharmacist Guide to Treatment, a second edition from CAMH, a physician must order all replacement doses. And as always, the pharmacist should document the details of the situation and communicate clearly with the rest of the treating team. With vomiting, underlying causes for vomiting should always be considered and addressed, particularly if patients are vomiting in repeated circumstances. And if this happens, you should direct the patient to follow up with their MMT prescriber, or if it seems like a serious cause of the vomiting, to send them to the emergency room for further assessment. So another sort of niche area of this already kind of niche area of methadone dispensing is, what if Ms. Green had been pregnant and then she vomited? So the CPSO MMT program standards discuss that for pregnant patients or patients with underlying medical conditions such as HIV or cancer, the patient's MMT physician may decide to prescribe a replacement dose of methadone even if the pharmacy or clinic staff did not directly observe the patient vomiting. So this is another very important reason to consider contacting the patient's methadone prescriber to report vomited doses. So, in the circumstance where a woman is pregnant and having a lot of morning sickness, then it is possible for the prescriber to still get that patient their full dose, even if the vomiting was not witnessed by pharmacy staff. But that would be at the discretion of the provider. And again, If it had been more than 15 minutes after the patient had consumed their dose, then I think it would be unlikely that the provider would consider re-prescribing any dose for that day. The next case study considers a patient that appears intoxicated or otherwise altered. So Mr. Brown presents to your pharmacy for his daily witnessed dose of methadone, 100 milligrams. However, today he appears slow to respond to your questions, and he's slurring his speech. You have the sense that he might be, high or maybe drunk or intoxicated somehow. So the CPSO MMT program standards state that if a patient appears intoxicated, the patient should not be administered a methadone dose. In these circumstances, the pharmacist should alert the patient's methadone prescriber, and the patient should be assessed. If a patient becomes intoxicated in the pharmacy after receiving their methadone dose, then this is highly suspicious for an overdose, and that patient should be sent to the emergency room by an ambulance. So you should call 911 and get an ambulance there to take care of that patient. And when the paramedics arrive, you should be sure to tell them that that patient just consumed a dose of methadone, as that will probably prompt them to give the patient naloxone. So moving on to the third part of this talk, which is focused on interprofessional communication and record keeping. I'd just like to remind everyone that the CPSO MMT program standards and clinical guidelines states that many problems in patient care have been found to be the direct result of a lack of communication between MMT prescriber and pharmacist. So the colleges are aware that this is an issue. And as I'm sure you're all well aware, that interprofessional communication is essential, especially in a few critical scenarios, such as determining at the outset if a pharmacy is accepting new patients for MMT, discussing how and when the pharmacist is to contact the MMT prescriber. As I mentioned before, this could be by exchanging cell phone numbers, developing means for the pharmacist to reach the MMT prescriber for urgent issues after hours. Again, this could be through cell phones or a pager or some other means. And documenting or relaying pertinent clinical information, such as pregnancy or vomited doses or missed doses, between the two parties, pharmacist and physician. There are many other scenarios in which communication is essential as well, but these are 4 critical ones to always consider. So, 3-way physician-patient-pharmacist agreements are encouraged to help facilitate this kind of collaboration, and a sample of such an agreement is given in Appendix G of the CPSO MMT program standards. This is in addition to an agreement between the pharmacist and the patient that covers procedural issues specific to the pharmacy, and might include, for example, code of conduct, as mentioned in one of the previous scenarios. So just as I mentioned previously, some True North Medical Center physicians provide their cell numbers to pharmacists that their patients regularly receive MMT from to help facilitate this kind of interprofessional communication and quickly resolve many of these scenarios. Talking about record keeping, so this is looking at, this is drawn from the Ontario College of Pharmacists MMT policy statement, which states that for every dose of methadone given to a patient, that the patient's name should be verified by photo ID, that the amount of dose that was ingested should be clearly documented, the date and time of ingestion as well, and the place where the administration and ingestion was observed should all be documented. And this is essential both for patient care and auditing purposes. And again, just reinforcing that pharmacists should, in addition to communicating these important clinical events to MMT physicians, pharmacists should also be sure to document that these events happened. So these events include vomited doses, dose adjustments, missed doses, stolen doses, or lost doses. Another good additional resource is the Ontario Pharmacists Association Opioid Substitution Therapy Drug Information Line. You can see the information and the hours of availability for this resource on the slide. The Ontario Pharmacists Association also offers an online forum called the Methadone Maintenance Treatment for Opioid Withdrawal Discussion Forum, accessible at the URL on the slide. Similar to the Opioid Substitution Therapy Drug Information Line, this is also a free resource available to pharmacists to help support them with their methadone practices. There's also the Connects Ontario Drug and Alcohol Helpline, and the number is there. This is formerly called the Drug and Alcohol Registry of Treatment, or DART. This is run by the Ministry of Health and Long-Term Care 24/7, and this is a helpline and online program search tool for patients and providers. So both patients and providers can call this helpline if they're looking for information about drug and alcohol treatment.